Thank you for joining us. This is Chris Prue, and my colleague, Dr. Proctor, got pulled away on something else, so you're going to be stuck with me for this presentation. And so I jammed a lot of information in here because I'm not known for my brevity, and I was in charge of the slides, so I've got a lot of slides in here, but so I do talk fast. But hopefully, some of this is going to kind of be a review, especially when we talk about overlapping of how, physical agents kind of work. I'm going to move from this full screen view to, the more didactic and PowerPoint. I often reference and pick things up and show stuff. And so you can actually have that picture in your frame. So that's up to you. A lot of people turn it off or kind of forget where it is. And that's okay. If I need to, I'll eventually cut back to the video view. But so for the most part, I am going to be referencing the slides and things like that. At the very end, I do give my email address. And so if you have questions, like I said, I think Judy, I ended up at 12:59, 1 minute before the hour, last time. So not a lot of time to answer questions. So you can email them, either to the registration event coordinator, and thank you, our wonderful Judy Taylor. During the event, I won't entertain questions during, but if you want to type in questions in the chat, so I'll do that again, and hopefully this will pop up for you. Right, so that's where you're actually gonna potentially put in some questions. Like I said, we're gonna kind of run right into the end of the hour, but if there's time, like I said, feel free to email if we get enough questions that maybe I need to send out to the larger group, then we'll do that. Otherwise, it's good job description, job security, for me, always answering questions. So without further ado, I'm going to go back to my share screen view here. All right, hopefully you can see that. So again, today's topic, which you probably already know, is clinical application of high power laser. So this is part of a series that we started last month. So for those of you that were able to join us last month, so you know that we covered acoustic wave therapy, specific radio pressure wave, and we're looking at continuing this because we've had such great response to it. So keep an eye out for the next one, which we think is going to be something related to NMES. And if we can, we're going to focus it on, post ACL reconstruction and NMES and management with electrotherapy in post-surgical ACL. So keep an eye out for that, and hopefully this will give you some information. When I'm asked to talk about laser, it's funny, we always go a little bit back and forth, because when I was first a professor in teaching therapeutic modalities, actually as a student, we didn't have high power laser or low power laser in our textbooks. And I think the first textbook I used when I was teaching it in the AT program was Chad Starkey's book, and it was on light. So it was a small section, but one of the reasons we still probably delve into this is some new literature comes out, but also to kind of clear the air with some of the claims that we hear. So hopefully we'll hear that. So conflict of interest statement, we put this in here because this can qualify as a category D, if you're an NATA certified athletic trainer by the BOC. And so I do work for the manufacturer. Dr. Proctor and I both do, as clinical people. So we don't get commission. That would be kind of cool. I'd talk to my boss about that. But in any event, that's just so you know. We put this in every presentation because Dr. Proctor loves it. I have it in others of mine in a little bit different form, but really about sort of the imagination. I think that's what's cool about some of us as clinicians is we have to kind of think through, and I always kind of joke you know, give an athletic trainer a roll of tape and they can pretty much do anything. And probably half that joke is I'm pretty good at that, but for whatever reason, I don't seem to be very good at wrapping Christmas presents. Maybe that's subconscious, and my wife has to do most of it. But we're gonna, like I said, we're gonna breeze through some of these components that we see in the outline here. Some things I'll spend a little bit more time on. Some things I'll spend a little bit less time on, just because of, again, the sake of time and really what we think is going to be very important and what we tend to get a lot of questions on. So first off, you know, looking at, well, where do we use this sort of thing? Where does it really shine? Because a physical agent is, you know, a physical agent, and they tend to overlap, right? So, you know, if you do have the screen on, I'm pointing at, you know, a combo device, and then I've got a high power laser here, and of course I have all this other equipment. And that's, I think, what's confusing to some people is, you know, how can there be so much overlap? Well, think about it, because we're using exogenous forms of energy to create a certain, you know, environment. And at the end of the day, our goal is very, very similar, which is to create a healing environment for the most part. Every single one of these, however, does shine in some aspect, right? So if your goal is to perform deep heating, I mean, even a hot moist pack isn't going to do that, because its depth of penetration is very superficial. So we got to go to shortwave diathermy or therapeutic ultrasound. If you want to get a muscle contraction, well, your only option really is electrotherapy, but yet you could use either one of those during the acute phase of an injury, you know, for edema, tissue restoration, and things like that. So that's why we see some overlap, and I don't want to get hung up on, okay, I use laser to reduce edema. Well, I know I already have other options for that. And hopefully what I'll outline is, you know, why this is the option that might be a better option in certain cases. Reducing fibrosing, remodeling of tissue and nerve flow, decrease pain, right? And same thing, we've got a lot of things that potentially decrease pain, some similar mechanisms, and then we also have some different mechanisms, and then to facilitate other modalities. You know, I put prior to exercise, for example, because if we can reduce pain, then it might allow us to do some other things, because pain in and of itself, nociception, reduces, you know, motor neuron excitability, or, you know, nerve conduction flow to the quadriceps, for example, you know, even if it's at sort of that subconscious level. So if we can thereby get to reduction in pain or edema related to the cause of that, that may shift that whole process and allow us to be more successful in some of the other things that we do. Least of which, and I use traction as an example because, you know, reducing pain and discomfort creates more relaxation, and for it to be successful is going to be important. I will admit, you know, of all the things I have, I think laser's probably one of the most versatile tools. I like to use traction because, you know, also as a chiropractor, and even in sports medicine, I mean, spinal injury, spinal conditions are highly relevant. Very, very powerful tool, but yet it's kind of for the spine. Well, I use it for shoulder and hip too, but, you know, versus, you know, what I can potentially do with laser. And sometimes, you know, we get comments, and it's like, you know, is this relative, you know, to athletic training, or it wasn't relative enough? Well, keep in mind that, you know, some of us work in that very, very intense sports setting with, you know, high level college athletics and professional and Olympics, but there's also the industrial, there's also, you know, the outpatient clinical setting. And so we work with a very wide range, and that's why not everything is just, you know, hardcore, you know, high intense athlete application. So that's cool. In general, I mean, that's what's nice about, you know, a modality, and why it, you know, this particular one is so versatile, is at the end of the day facilitating healing. But we can really do a much better job today, you know, at identifying, well, sort of exactly why. I don't want to spend a lot of time on the history of it, just because as much as I like to, you know, have that discussion, we don't have a lot of time. So, but it's not new. The therapy's been around a really long period of time. It's just, where are we kind of focusing our efforts? And, you know, in our world, I think you know, the neuromusculoskeletal, we're kind of looking at regeneration or restoration of certain tissues that we tend to find: muscles, ligaments, tendons. You know, again, if you're in an outpatient market where you're dealing with chronic conditions like OA and things like that, you know, we think about that. And then we have to have the discussion LLLT, low level light therapy, which includes low level laser therapy. And that's what high power laser is. You know, a lot of people have this misconception that there's low power laser and high power laser. That's not the same as low level laser. And we'll look at that here in a second. But, you know, the earlier work and why we called it low level laser, because we didn't have, you know, a high power laser and a low power laser, was because, you know, it was used to treat very, very superficial conditions. And I want to point out, especially when you look at skin defects, diabetic ulcerations, bed sores, venous insufficiencies, what's the consistency there? What's the overlap? And they all limit in, you know, nutrient flow, blood flow, especially oxygen, right? And so I want you to, you know, put that in the back of your mind, because we're going to talk about that as we move forward. But the other thing that a lot of these things had in common was they were very, very superficial. And so the Ruby lasers worked really well because you didn't need a lot of power. And in fact, you don't need a lot of power, you know, to deliver the energy. It's about time. Now, if you talk to a physicist, they'll say it doesn't matter whether you have a high or low. It's a component of time. Well, we're also a biological system. So some of that energy, because it does abide by the same laws of light, biologically can potentially dissipate, right? So low power versus high power. Why are they both called low level laser? Because low level laser in our world is a non-destructive laser versus, you know, what you're seeing here. These are cutting surgical destructive lasers other than, you know, the therapeutic lasers. And those are much higher powers. I have a slide here in a moment here that shows, you know, an industrial laser, which is even more powerful, right? So it's not just about cutting through skin or cauterizing. It's actually about cutting into metal and, you know, other types of materials. So the other, you know, why laser? And I don't know, maybe it's just a trivial question, which is interesting, but it comes from the acronym, right? So that's what I'm saying is it's been around for a very, very long period of time. And it's appropriate, and it's just, you know, maybe not as cool as it was when it first came out. But so there's a picture of looking at this, you know, cutting laser. That's a high power laser, you know. So that is different than what we are using, and why even, and I'm holding up what's referred to as a high power laser in the therapeutic market, which is 20 watts, which actually can burn. It can't cut, but it can burn because it can become hot, you know, if you don't use it. And it's not to freak people out or scare people, but so does ultrasound, right? If you're in a thermal application and you don't move that thing around, you can burn tissue. And actually you can create, you know, irritation to the periosteum, even of bone tissue, which is arguably much more dense than skin tissue. So that term is quite relative. Low level laser, right? This is still a non-thermal modality. It doesn't increase tissue temperature to any great extent in large surface areas, which is why, even though it generates heat, I still have to move it around. And so we don't really think of it as a thermal modality because it's minimal, but it's enough to have certain, you know, chemical properties to it that may enhance the outcome of a particular application and therapeutic benefit. So the laser classification and why we have high and low power laser, and that is more sort of marketing or industry, to where we don't have a clear designation between high and low power, right? Most people will say that a high power laser is a class 4 laser. But if we look at this chart, which is, you know, produced by the FDA, so the FDA classifies these based on eye injury hazard. You know, how easy is it to damage the retina in someone's eye? And why is that? Well, because the wavelengths that we're typically using, especially the infrared, the longer wavelengths, we don't have a blink reflex, and so The other thing is that this light can actually penetrate your eyelid. So even if you close your eyes, and that's why I'm holding up my little buddy here, which is wearing the fancy glasses that we use, because it blocks the specific wavelengths in your lasers. So that's why you can't just go get, you know, those glasses that they use at the optometrist, because when they dilate, you know, they use something that looks like this, but it is not this, right? So you got to look, if you could read the label on the side of those glasses, it's very specific to the wavelength range. So that's important. So a class 3 laser is less than 500 milliwatts. Class 4 is greater than 500 milliwatts, and that's per diode, right? So when we look at this eye injury hazard classification, we can kind of see that, you know, in our therapeutic market, we have, you know, both class 3 and class 4 lasers, right? Like I said, especially anything that can generate heat can be potentially detrimental. And that's probably more so the reason why, well, it is the reason why it's a little bit more dangerous, because it doesn't take a lot of energy, you know, to change that. So that's why we even wear glasses using the class 3 laser. And then I have a picture here that a YAG laser. So we'll get into this a little bit, but the generators of each laser to some extent will dictate sort of what the wavelength is going to be. So this is a gallium aluminum arsenide. We've got helium neon, we've got gallium arsenide, and these YAG lasers, excuse me, generate a wavelength of 1064, and they're very high intensity. So they tend to be 60 watts and higher, upwards of 100 watts, right? And so a lot of those were originally developed as higher power lasers, right? Not specifically for the therapeutic market, but they were kind of governed down into our world, you know, using a governor or a duty cycle for the most part. So we'll get into, you know, why, even though it has more power, it has more to do with wavelength on your depth of penetration. Wavelength, let me repeat that, wavelength on your depth of penetration, most important. So, all right, I don't want to spend a lot of time on this, but essentially, well, how does it work? You know, it's not that much different than, you know, normal light. There needs to be some excitation of energy. So, you know, we pump up these photons, and we have a generator. And in this case, you know, gallium aluminum arsenide. The older, the ruby red lasers, helium neon. And this is actually, you know, kind of that depiction. And so it excites this energy, and then we force it through a diode. And in this case, a laser diode, and it produces a laser light. And we'll look at these characteristics in a second here, but that generation of energy, or that characteristic, is kind of why we're having this discussion today, because it has certain characteristics that enhance depth of penetration as well as energy consumption. But as technology grows, I mean, some of those characteristics can be found in some of these other sources of light. Nonetheless, light is light is light. So even though it has very special characteristics, and we minimize some of these to some extent, but we still have to contend with reflection, scattering, absorption, and transmission, right? And so, you know, we have certain models to where we can consider that, because if I'm treating an elbow, such as a lateral epicondylitis, versus you know, an injury deep in the iliofemoral joint, like a labral tear or something like that, the depth of penetration makes a difference because of some of these principles. So in other words, I got to figure out, you know, how much energy is actually going to make its way down. Fortunately, we do have some answers to that. We also have some software that, you know, potentially deals with that. So really the characteristics of laser and why, you know, we've gravitated towards this form of light: monochromatic, coherent, and collimated, right? These are all characteristics that create a very consistent stimulus, right? And so cells can communicate via certain frequencies, infrared frequencies, within that electromagnetic spectrum. And so think about, you know, I always use the analogy of exercise, that, you know, me exercising, you know, 1 day a week, first off, may not be enough stimulus to create an adaptation, right? Which is why we have guidelines, 3 to 5 times a week for, aerobic type exercise, 2 to 3 times a week, for anaerobic type exercise. And so is one day going to do it? Well, it's a dose response thing. But also, if your goal is to get a very specific adaptation, so let's say in that strength training, one day I'm doing really, really high reps and I'm doing, multiple sets, extremely high volume, even though the overall volume load is relatively low just because of, the number of repetitions I'm doing. And then on the next day, I do, a very low repetition range and a high percentage of my 1 repetition maximum. I'm in kind of 2 different areas of resistance training, right? So one maybe a little bit more endurance, hypertrophy, and then the other one really is strength. So again, my expectations is I'm not going to really maximize that benefit from either one of those. So that's why, when we look at the monochronicity, the coherence, and this collimation, is it delivers a very concentrated form of energy. So it's a concentrated stimulus. So that way we're delivering it. And if you think about it from a pharmacokinetics or a hormone situation, I release thyroid hormone, and the more thyroid hormone, the more hormone in general I release, it's going to attach to more receptors and therefore get a response, right? And so it's somewhat similar here. And that's why also we look at wavelength, because the wavelength also has a dictation to what exactly it's going to stimulate. Now, the good news is there's a lot of overlap, and we'll talk a little bit more about this here in just a moment. But so when we can create a more specific, stimulus, we should thereby also get a more specific response and adaptation. So the laser frequencies that we're using, or excuse me, the wavelengths that we're using in the electromagnetic spectrum typically range between 600 and 1,000 nanometers. They get a little bit less and they potentially get a little bit more, but that's what dictates, some of the things that happen to us. And that's why it's changed a little bit over the years, because, well, we're better at identifying some of these characteristics. But in general, we get light stimulation to a cell or a tissue. The individual cells respond to that because we have receptors. We've got photoreceptors on the cells, and then even certain organelles within the cell also respond very specifically, right? So I was joking, remembering back to chapter 2 or 3, depending on your textbook, the picture of that cell that kind of looks like the Earth, right? It's got all these different pictures, and there's 90 degrees cut out of it, and we see the nucleus, all that stuff. But no cell really looks like that, right? But remember, on that phospholipid bilayer, which also tends to be very, very colorful, we have tons of different receptors, right? We've got hormone receptors, based on that sort of lock and key effect. So receptor for all these different hormones. Ligand gated channels, right, that respond to different types of voltages or electrical conductivity. So multiple things, and one of them are going to be photoreceptors. So in the case of laser, and what's cool with is within that specific wavelength that we're talking about, in instances, it actually makes its way all the way into the cell, right? So it's almost like a steroid hormone, because it can actually go to, specific organelles inside of there, other than just typically telling something what to do. Which is also why we get, multiple things going on, and why we can get stuff like protein synthesis, cellular proliferation, eventual tissue repair, and then like pain control. So remember, we use this term biomodulation or biostimulation, right? So stimulation, remember, doesn't always mean turning something up. It means that it creates a physiological response, right? And that physiological response could be excitatory or it could be inhibitory, just like we talk about in some of these other things. So, light can enter the cell and, again, interact with some of these different things. In particular, what we have known for a long time is, its interaction with the mitochondria, right? Again, not to bring up bad memories of physiology, but I feel like, if we have a really good understanding of our devices and application, and you understand the pathophysiological process of someone's condition, it makes it a little bit easier to make your choices. And then going back to that Albert Einstein, the imagination of, not everyone presents exactly the same way as a protocol written in a book or in a piece of literature. So worst cases, the only thing that laser did was stimulate metabolic activity, right? I think one of the really cool things is not just stimulate metabolic activity, but we have to think about how it really does that. And so it increases the uptake utilizing an ionic shift of oxygen, right? So remember, again, now bad memories of chemistry, but and physiology. So when we suck in oxygen, we breathe in oxygen. Obviously, we're breathing in carbon dioxide, oxygen, and nitrogen, right? So, but the oxygen we're breathing in is diatomic, meaning it's O2, right? Because it's not stable by itself. But when we use it and we metabolize it inside the body, it's separated. So that, outermost octet in the in that particular element is not stable. That's why it needs to connect to something else to be stable. So, but when it's not stable, that's actually how we use it, because oxygen is taken up, and in that cytochrome activity, it's an acceptor for 2 hydrogen ions, right? So the byproduct is H2O, which is easy to metabolize. It's wonderful. So it's actually that ionic shift, which is really important. So this is why just the presence of oxygen isn't good enough, and why hyperbaric chambers are only going to get you so far, because sort of back to why the use of oxygen in those hyperbaric chambers was pretty good in those conditions we talked about, diabetic ulcerations, for example. They're limited in oxygenation, to the area, but it's kind of at that more chemical biological level, right? So it's a delivery and an exchange situation, not just a delivery, right? And then there's 2 other characteristics associated with that. I drink a lot of water when I speak. It's very dry this time of year. But so another characteristic of reactive oxygen species is, metabolizing that oxygen that's not used for this process, right? Because it's a free radical, and it can create, excessive fibrosing, which is something that we don't want. So one of, the important factors for me, and why it's pretty important to utilize, especially during those earlier stages of an injury, is it stimulates this process of an enzymatic reaction to metabolize free radical oxygen. And we measure that with an enzyme called, superoxide dismutase. And that's important for me, because that tells me that, I'm also minimizing the fibrosing stages, right? So we've already talked about this in pain relief, because again, people are like, well, how can it, enhance tissue reproduction but block pain? Well, remember that that's just a physiological process, right? Same thing when we look at how can something be anti-inflammatory but yet be an increase in microcirculation, right? It's chemical mediated, and so we're really enhancing, that process. That during the acute stage, the inflammatory stage, we're trying to mediate, those chemicals, interleukins 2, 3, to be anti-inflammatories. And then during the microcirculation stage, when bleeding's controlled, we want to stimulate like interleukin 6 and 8 to enhance microcirculation for the delivery and concentration. So when it comes to the chemical mediators associated with pain, but also nerve conduction, this is where we get it. You can see a bunch of arrows, and so it facilitates a lot of different chemical mediators, and can depolarize, small diameter nerve fibers. I've been talking a lot today. So when we look at, all the things that it can do, that's why it's biostimulatory. It's not starting a bunch of new things. It's working with the body, very similar, like I said, to other physical agents. And again, if you have me on video, I'm kind of pointing to other things, but in that it's really facilitating, these changes. So when it comes to the dosage, so we've got, some literature, we've got some information that kind of lets us know. And the best news is that it's not a lot of energy. And that's, to me, that's awesome, because when we think about the various stages, the continuum of an injury to eventual resolution, we manipulate some of those parameters. And so if during the early stage doesn't require a whole lot of energy, it probably means that, it's not going to be contraindicated. It doesn't take a lot of time. And with laser, there's a direct relationship between laser, the time, and the dosage, right? It's related to your power output, so how much power you have, which is kind of why we'll get into that discussion in a moment. But that's important, because if the dosage, even if you don't know this yet, but so kind of the statistical, significance starts at around 0.5 joules per centimeter squared. Even if you don't know that, that's our measurement. And let me tell you that that's not a lot of energy. It doesn't take a lot of time. All the way up to about 20 joules per centimeter squared, our sweet spot is about 6 to 10 for the most part at certain stages. That's important because it's like, okay, I want to teeter on that fine line. I want to deliver enough energy to capitalize on my treatment. But if, another 5 or 10 minutes per treatment only gets me another 1% return, maybe that's not beneficial. It might not be clinically significant, and it might not be, significant in the outcomes. And then the other side to that is we want to make sure that we introduce enough energy to get, the outcomes. It is probably one of the physical agents that has the least amount of contraindications to it. And I have them at the end. I don't talk a lot about that. You can read them, but there's very few, contraindications to it. And that's the beauty, is we don't need a lot of dosage. Now, it's kind of like, some of these other things, that if you're over consuming huge amounts, it can be detrimental. Usually it's detrimental in the sense that it can slow down, especially during the fibroblastic activity stage. What's interesting is when we dose healthy tissue, there's really no negative side effect, which is interesting. In fact, normal healthy tissue does a better job at absorbing light than unhealthy tissue. Well, it kind of makes sense, because metabolically it's more active, and it's just overall a little bit more functional. And then, kind of related to where it works and what it facilitates, because now we're in this realm of multiple wavelengths, because we've got better research that shows us, historically, there's so much information and data, which I think is confusing to people, on that 632 nanometer wavelength, right? The earlier red ruby, helium neon stuff. And so everyone's like, well, that's it. It is. It's the cat's meow. I mean, it's an amazing wavelength, but I'm going to show you something here in a second. So, but this graph represents, maximizing where we find the absorptive capabilities on these specific components, such as hemoglobin, melanin, water in particular for absorbing thermal energy, and then cytochrome C oxidase, which is the whole metabolic activity and reactive oxygen species, nitric oxide, and so on. And so if we look at, this graph, and we see where most of them, sort of intersect, the 660 is it, it's wonderful, right? And so you would think, well, that should be my go-to. Well, it doesn't maximize, any single one particular, except for melanin, which is okay. But if we look at, the graph with cytochrome C oxidase, we see that this 800, so really between the 800 and the 900 nanometer wavelength, gives us that maximal stimulation of metabolic activity to the mitochondria, right? So you kind of need, you'd think about, where do I want to maximize my benefit? Well, let me also tell you that wavelength not only has to do with, the physiological outcome per se. There's tons of overlap, as you can see just looking at this graph, but we look at these next graphs, and it also has to do with the depth of penetration, right? That's the downside. That 632 really kicked butt in the world of metabolic activity. But again, back in those times, we were more so dealing with more superficial things that were going on, you know, skin ulcerations, diabetic ulcers, so on and so forth. So yeah, that works great for superficial stuff if I'm using the 660, but the problem is the depth of penetration. Most of it's going to be absorbed in, you know, the first several millimeters, you know, within the first centimeter or two. So then we look at the depth of penetration, and the one that actually has the best depth of penetration is actually between the 800 and the 900, right? So again, that's kind of parabolic. When we look at the depth of penetration, you would think that, well, it's more power. It's not about power. Power is dosage and gives you your energy density. It's wavelength that influences the specific physiological outcome and the depth of penetration. So that's your main concern with regards to what it is that you would like to accomplish from a physiological standpoint and the delivery to the depth that you're trying to treat. And for most of us in, you know, this physical medicine world, yep, we used it as an antimicrobial when, you know, MRSA was such a problem. We had, you know, people come into the training room with open wounds and basically irradiated everyone with open wounds with it. But, you know, we're really kind of looking at, you know, hamstrings, shoulders, feet, lumbar spine, thoracic spine. And so depth of penetration is really important, you know, to a lot of us. And so think about that, you know, yes, that 632 and why there's so much literature on it was because that was just the most readily available, you know, device back in the time when a lot of that research was being done. So it is in that 600 nanometer wavelength, you know, realm. It's awesome. It's an amazing wavelength, but it's especially good for things that are relatively superficial. And let me show you another depiction here. So this is using a spectrometer, right? So we're shooting it into some type of device that measures, you know, light concentration and energy. So we're looking across the gamut here from the 660 all the way up to the 1064. Remember, the 1064, I said, also has the largest amount of energy to it, right? So the 1064, this particular depiction uses a 60-watt laser output. And, you know, the other wavelengths are, you know, the 800 has the highest, the 600 is also, you know, fairly minimal. But, you know, look what happens when we shoot it through your thumb. The 880, most of it is still, you know, making its way, which take that into consideration too, because if you are treating skin wounds and that's your only deal, then, well, you may not want the 800 because it's going to blow right past, you know, where a lot of your stuff is having your problem and your pathology. But look at the 1064, it's almost non-existent. So it doesn't even make it through your thumb, you know, in comparison to other parts of your body. And I know what some of you are thinking. It's light. It doesn't make its way through anything. Well, we beg to differ, because in that 600 to 1000 nanometer wavelength, you know, it's shown to get upwards of 6 centimeters deep, which is significant. And I'm going to show you a picture here in a moment, you know, just looking at an LED, right? And so this is a good depiction of, you know, the depth of penetration, right? This was my daughter. She's 8 now. So she was 7 years old. I was treating a mosquito bite. That's a whole nother story, but it's a great anti-inflammatory, it's antimicrobial, great deal of effect to it. But in any event, I'm using, and again, if you're looking on video, you can see my little picture here. You can see I'm holding up that actual applicator, which is a cluster probe that has both laser diodes and LEDs. The laser diodes are infrared, so you can't see those. So this is actually the LED. This is an LED, red LED, and yes, it's going through the back of her ear, right, which is going through 2 layers of skin and obviously the cartilage, and a pretty dense cartilage at that, right? I do this little trick, in some of my seminars, and I went to the dollar store. I bought these different colors, and all of them, red goes through the deepest, but red, blue, green, yellow, and they all go through. So it's kind of interesting when people say, it doesn't go through stuff. Very much so. And that was, an LED at only 10 milliwatts, right? Which is significantly smaller. So we're looking at, depth of penetration and influence. And that's why I spent that time on wavelength, right? Because if I can't get to the tissue, then I'm really not going to have much of an influence. Worst case is you use a superficial treatment, and it does help to modulate pain. So even if you're treating a hamstring injury and you're using that 660 nanometer wavelength, it really does actually decrease pain because it stimulates an opioid response, which is wonderful. You're just not getting the tissue healing benefit that you would if you had that somewhere between the 800 and the 900. So one of the other reasons for this go-to, and I'd already mentioned this earlier, is this fibroblastic activity. And so what's, I think, especially unique about this form of energy, even though it's electromagnetic, it's not even mechanical, but yet it has the capacity to take tissue like tendons and ligaments to go collagen 3 to collagen 1 and actually increase the ultimate tensile strength of tissue, even before we start adding mechanical energy to it. So that actually creates a nice, strong, biased tissue, even without, doing a whole lot of extra work, which, I equate that to, quicker return to play, quicker return to work, whatever your population is that you're dealing with. I think we've done enough with metabolism, and I just love showing this picture, and it reminds us, how complex that overall process is. And I've already talked a little bit about this. So laser's unique, and it acts kind of like a steroid hormone. It enters the cell and it stimulates the nucleus in DNA through transcription translation, right? So it stimulates the rough endoplasmic reticulum, which is, something that's a pretty powerful tool in why we get protein synthesis and all this tissue activity in terms of restoration, which is again, for something that doesn't take a lot of time and something that doesn't require a lot of energy, it's easy to irradiate and use this form of treatment even during very, very acute stages of injury. And then, like I said, worst case is if you're managing pain, and this can be potentially, like I said, as part of your versatile tool, is it's been shown to enhance both, chronic neurogenic type pain up to the acute stuff, to where it influences. I'll show you an article here in a moment. The chemical mediators associated with acute pain. So that's a nice thing. Is it's addressing the mechanisms associated with the cause, right? For us, that's important. That's a key factor in resolution and trying to use what's optimal for our time. I write in quotations, good literature, because I'm going to blast through this. And the reason is I just want to make a point, and that we know some stuff is out there. Comparative analysis, using laser and electrostimulation in wound healing. And I know this is a rat model, but there's plenty of human models. Actually, there's a great article of 2004 by Dr. Ty Hopkins, and they did a great job. One, I think it's awesome because it's from our Journal of Athletic Training, but two, because they used a human model and triple blind study. Actually, I think I even have that in here. But in any event, here's what's interesting in this particular study is we saw that they were both, efficient and successful in clinical significance in resolution of a wound. Well, why is that important to me? Well, if it took me 15 minutes to accomplish that with electrotherapy, but it only took me 1 or 2 minutes with laser, and it was a wash, right? The outcome was the same. I value my time, right? And so, when I worked in a training room and, we open the doors and a lot of people come in, efficiency and management is important, even in outpatient. So even an outpatient, It's also important because, you know, I still need to see a significant number of patients. So time-wise, you know, that's pretty awesome. Um, and so depending on even a large surface area, a very large surface area, you know, in the lumbar spine, I can use, you know, a high power laser and be done in 5 or 6 minutes. And, oh, I did put it in there. Hopkins et al., you know, the triple blind study. That's why I like that one too, a triple blind study. You don't see a lot of those. But in any event, see that what was particular interest in that one is, you know, in a certain parameter, an accelerated rate, because one of the things we always talked about in physical agents is we don't accelerate, we only maximize the healing environment, right? And so it may seem like we accelerate because maybe someone doesn't have, you know, good physiology anyway, good health, like in the diabetic ulcerations, but using a, you know, healthy population, which is code for we're using our students and giving them some extra points, but, you know, to introduce a wound onto them. But so I feel like that was, you know, that was an interesting and an important study. This next one is, you know, using bilateral Achilles tendonitis, and so they actually act as their own control. So they measured, you know, pain from a visual analog, and you go like, okay, well, you know, when I put on these really cool glasses, it does enhance the placebo effect, but that's why we also actually measure, you know, some of the causation in that situation. And so, you know, it correlates to a decrease in prostaglandin E2 concentration. So we know that it's actually reducing the chemical mediators associated with what's causing acute pain. Collateral ligaments, ultimate tensile strength, that conversion, like I said, even before adding mechanical energy. And then again, for me, what's important is reducing that fibrosing. And then lastly, what I think is also important is, you know, identifying, are we doing enough and are we maximizing that benefit? Because here's a challenge when you're using laser, you know, a high power laser, because it does generate heat, you can feel it. And I think that helps to alleviate some of the issues. But we always joke about, you know, ultrasound is, was it even plugged in? And, you know, what was the benefit? And from the clinical perspective to the patient perspective, you know, not feeling or not identifying that, it's a challenge because, you know, there's an association also between patient satisfaction and even clinical outcomes. But if you're in that setting where, you know, you are outpatient, it does make a difference, because I know we don't want to talk about money and you know, but in outpatient, we do have to have patients, and, you know, they have to pay. So we want to make sure that that we have, you know, high satisfaction. So in any event, what we do find is that when we maximize a particular, you know, physiological process, such as, you know, reducing chemical mediators associated with pain, that we know that it's like turning a light switch off. So for inflammation, you know, once it's off, it's off. I mean, you can't push down on that light switch anymore, and it doesn't go any more off. Off is off. And so I think that's one of the unique aspects that we find, that, you know, there's not a lot of benefit to overlapping, you know, physical agents because of the reasoning that, you know, they're actually successful, at least for the same reason, right? And then, you know, what I like about this study by Josevich is that one of the things they found was it doesn't require a whole lot of energy. So even using a spot size in creating, you know, a very significant outcome, which is awesome. So some of these were biological, you know, physiological outcomes, you know, showing clinical significance in a certain, you know, parameter with regards to a tissue. I know it always comes back down to clinical significance, and so part of it, you know, may be some extrapolation, but in general, decreasing pain is a good thing. And we know that when we do see a decrease in pain, it does facilitate it via, you know, chemical mediators, as well as neurological. Reduction in overoxidation and scar tissue formation, fibrosing, again, is pretty important. And maximizing that metabolic activity for tissue regeneration and enhancing the ultimate tensile strength of tissue. And then, like I said, for me, in minimizing pain, so then we can go do some of our activity. Because remember that, you know, pain in general is a negative thing. And so reducing pain and then having someone do their exercise therapy, we tend to see a higher volume load, right? So that has a direct relationship to progression. Imagine doing a motor control type of exercise, even walking on a treadmill. I don't want patients walking on a treadmill with antalgia. And so if we can reduce their pain, then their therapeutic exercise becomes essentially more therapeutic. So we're going to have a brief discussion here on power, right? And because this is kind of what we're into and why we're having this. But power has basically everything to do with delivering the dosage. And remember that, you know, if you go back to some of these slides and we look at, you know, the loss due to absorption in more superficial tissues, we have to take that into consideration. So our ultimate goal is energy density to the target tissue. And so we want to get to that therapeutic window. And remember that, you know, that therapeutic window it's about the same whether you're superficial or deep, but because of loss of energy when we go deeper, we have to irradiate longer, right? So if I'm using the same device, but with higher powers, it's easier for me to deliver that because it doesn't take as long with higher power. But also, I can treat larger surface areas, you know, at that same time instead of, you know, small points. And I use class 3B laser and my class 4 laser, my low power laser, my high power laser. They're side by side, because if it takes me less time and I've got a really small area, but if it's a large area, you know, knee replacements, they're huge, you know, with regards to dealing with the inflammatory cycle, lumbar spine, hips, things like that. And so, you know, to get to that therapeutic window and the appropriate dosage, I want to make sure, you know, I have enough power. Now, the diodes in these configurations are kind of interesting because we're seeing some really cool stuff come out with, you know, light emitting diodes, which is awesome because we can get some depth of penetration. Again, the problem that we tend to deal with is light emitting diodes, LEDs, you know, historically have been at shorter wavelengths, so more superficial, but also lower powers, right? So we're actually, light emitting diodes, you know, come in at the sort of the class 3A. And so really the laser is still our go-to at higher dosages because it has a potential opportunity for more energy accumulation. Superluminous diodes are kind of a tweener between LEDs and laser diodes. They're still collimated and monochromatic, so you're still getting some good energy density, but they're non-coherent, so they're not in phase. And then again, we look at the LEDs, and they're non-collimated and non-coherent, but they're monochromatic. They're the same color. So like I said, you know, we're losing some of that, you know, concentration of energy, which can potentially have an influence on the overall outcomes. But so we make up for that to some extent. I'm going to cut to the widescreen here and show you some of these different probes and things like that. But that's why we use a cluster probe. So, you know, at really short wavelengths that I am trying to do superficial, it doesn't require a lot of energy. In fact, if you use a lot of energy in a 660 nanometer wavelength, you can heat up that tissue significantly, and that's not something that you probably want to accomplish. So let me show you an example here. So here's a difference in energy. So this is milliwatts, right? So 500 milliwatts is half of a watt. And, you know, the guy I have in front of me here and the one next to me here is a 20 watt, right? So that's 20,000 milliwatts, okay? So here we're just talking about milliwatts. So to deliver 4 joules of energy with a 50 milliwatt laser, which is, you know, older, you know, handheld pen style, it takes 80 seconds to provide that delivery, all the way down to 500 milliwatts. You know, that takes 8 seconds. So with a 20 watt, it's a fraction of a second. Why do I use 4? Because 4 joules per centimeter squared, you know, so if you're looking at the surface area per diode, is about that level at which we do see an opioid response. So a long-term effect to pain modulation. So with a high power laser, I can actually cover a very large surface area to get that dosage in a relatively short period of time. So it really allows me to hit that peak window of opportunity. Pulsing. So pulsing, if we think about it in terms of similar to ultrasound, where we think that, pulsing reduces the overall energy. So that's potentially a good thing because we don't have to use as much energy. It might actually be inhibitory during the acute stages. But if we can go all the way up to what's considered to be super pulsing. So in super pulsing, we're at 20,000 hertz, right? So that's 20,000 impulses per second, but you need a lot of power to be able to turn off and on that quickly and actually capitalize on that energy density. So the benefit of super pulsing with a high power laser is it allows for better penetration. So there's less absorption in the superficial tissue, which actually gives us a little bit better opportunity for the delivery of energy at a greater depth of penetration. Okay, so I want to quickly go over this concept of how we're prescribing these dosages, right? So I use this example of the algorithm that we have in this guy here, the cube laser. And so the area in treating a lumbar spine condition, such as a disc pathology, we use the area of 210 square centimeters. Why? Because we're looking at the average area that has the greatest amount of influence per hour benefit unit of time in facilitating reduction in pain, right? So our target is a biostimulatory dose of 6 joules per centimeter squared at a depth. So if we're thinking of the disc at 6 centimeters. So with these other lasers, you'd actually have to run the calculation and look at the attrition in these wavelengths, right? So at 6 joules per centimeter squared at 210 square centimeters, I need to deliver over 1,200 joules, right? And so because of attrition, what that means is at the surface, I have to set my device to over 4,000 joules. So to alleviate doing all of that math, today's devices and technology give us the ability to, use an algorithmic approach to that. And so the benefit is, less time thinking about that, but actual consistency in the delivery. So this is tested, with a specific wavelength and with the power output. So we know it's successful in that particular delivery. And, to cover with a wand effect, those very large doses it's very difficult to accomplish with a class 3B laser. And so to deliver 4,000 joules with a low power laser it's not impossible. It's just, it may take you 30 minutes to 2 hours to accomplish that same thing if that was going to be your goal. You can read the contraindications. There's very minimal, mostly over areas that, we don't know. I always joke that direct irradiation over the fetus, we don't know. It's like some of the other things. It's just an automatic, well, who knows? It may produce super babies at some point. And I'm not trying to belittle, that potential negative situation, but it's just that we don't know. In general, we've seen some of the least amount of side effects. So reduction in edema, reduction fibrosing, facilitate tissue remodeling, decrease in pain, acute chronic pain, and like I said, to facilitate some of these changes in other modalities. So chris.prue at djoglobal.com. I think we've got like about a minute and a half. So I'm going to stop sharing that because I think there was some posting on the chat here. So let me go to the video here. So let me show you. So this is a class 3B laser. I hope you can see my video. So there's multiple diodes to it, right? And the silver ones you see are actually the laser diodes. So there's different configurations of diodes. So depending on your device. So this attaches to this. And here's a single diode laser. So this is a gallium aluminum arsenide, and it uses a diode output. The energy production is going to be released from the laser diode here versus this guy here. So this guy is a high power laser. So this one Total accumulation is 1 watt. It's 1,040 milliwatts with all the diodes. This one's 20 watts, right? So 20,000 milliwatts. So there's an optic here, but there's individual diodes that then have a fiber optic. So they're still released singularly. So they're not combined with a coupler. Some manufacturers do that. It does influence your laser output. So that's something that you're going to have to kind of, decide and look into and figure out, what it is that you would like to use. So let me see if there were any questions. Will you share your notes after the webinar? It would be my pleasure to do so. Again, I apologize. We're right at that time frame. So shoot me an email or shoot Judy an email, and I'm more than happy to share these. It's similar to what I used, when, gosh, I haven't been a full-time faculty now for 7 years, but so it's similar to what we use. So I'm happy to share this. I mean, we're supposed to be, colleagues and sharing this type of stuff. And so absolutely send the information to me or some other folks. So let me know if you have any questions. Give me a holler. I hope everyone is safe out there. I hope you're getting back to some semblance of normalcy. It's probably not true, but or maybe this is the new normal, and keep up the fight. So have a great day and keep an eye out, because we got another one coming up. Well, hopefully we got many more coming up. So take care.